Hello, Kinesiology 107. Today we're going to be going over Chapter 1, the injury examination process. So, to kind of start us out, hopefully you guys remember from Kines 106 that we should have some type of system in place when we're doing our evaluation. Now, whether that's SOAP or HOPS, SOAP stands for Subjective, Objective, Assessment, and Plan, or HOPS is History, Observation, Palpation, and Special Tests. Whatever one you use, we need to make sure that we are doing it systematically. We need to make sure we're going through certain things. And if we're skipping or jumping around, there's a higher likelihood or probability that we could potentially miss something when we are doing an evaluation. Baseline measures are always good if and when that's possible. You guys will hopefully remember when we talked about concussion baseline testing. That way, if and when somebody does, or you suspect that somebody sustains a concussion, we know what their normal was, their baseline, so to say. Because then we're not, if you can't remember the months of the year in reverse order when you don't have a suspected concussion, it's not fair for us to count that negatively towards you when we are assessing you for a concussion. So baseline are always good if that's possible. And one of the things that we do within athletics and sports medicine for a baseline is make sure that everybody has a PPE, a pre-participation exam, or a physical. And that just shows that they're healthy and well enough to participate in whatever particular sport that they're doing. Then throughout their season or sporting career, we do reevaluations or evaluations when we're figuring out what's going on with them. And then, throughout that course, we will continue to reevaluate and make sure that we're starting to head towards their goals to eventually be able to go back to 100% participation. The other thing that's important is documentation. We are such a litigious society, and it doesn't happen unless unless you've recorded it. So we need to make sure we are conscientious and taking accurate records for our patients, which happen to be student athletes. It is not only legally required, but a great communication tool. You can send your student athletes to their doctors or to their physical therapist or to their chiropractor, to their dentist, with your notes on whatever the injury is and what you've been doing. And that's a great way instead of trying to play phone tag. So when we're looking, and hopefully you guys are remembering, it's starting to kind of bring up all that stuff from our last course, comparing bilateral. Okay, so if I have an injured shoulder, I want to make sure I'm comparing bilateral, and I would do my evaluation on the uninjured side first. That way we can tell what good is. Now, the exception is if that other shoulder or body part has been injured in the past. Then it may not necessarily be the best thing to end up trying to compare those. It is important for history to see what their past medical history is. Whether the injury that you're looking at on that particular side, has that ever been injured before? Is this a new injury, an old injury? And then with the good side, so to say, has that been injured before? If it has, like I said, it might not be the best to compare, but you can kind of take that with a grain of salt. And then it'll provide a good functional assessment as far as what you can do on the injured versus the uninjured. And another thing that I always do is make sure you ask if they're right hand or left hand dominant, or right foot or left foot dominant, because that does play a part. Usually their dominant side is going to have a little bit more musculature, a little bit more control than the uninjured side. Just as if you're right-handed and you're used to writing right-handed, if you try and write left-handed, it's not going to be as perfect because that's not your normal mode. So other things to look at for inspection, it's giving you a symmetrical opportunity. So just because it's easier, if I have my wrists, right, and I'm looking at my wrist and say this one's injured and this one's not, we're looking at things, what about coloration? What about swelling? Any type of deformity? Are there any scars on there before? And then we're going to palpate. Palpate is just the medical terminology for touching. right? Is there symmetrical bones? Are they more point tender in a particular area compared to the other side? Looking at the different stability and tissue tests, that's going to give you a good information on the end fields, meaning when we're doing a special test. And this is going to make more sense when we go further in detail for those particular special tests of the different body parts. Neurological and vascular screening always need to be done, and we want to make sure we're checking distal from where the injury is. So again, I was talking about wrists. I want to make sure I'm checking distal, so I would be checking cap refill for vascular because it's looking at the blood flow. Neurological, we're testing the myotomes, dermatomes, and if it has reflexes, can they move it? Can they feel the sensation? And now going on to our clinical assessment. Is this an acute injury? Is it a chronic injury? How long has this been going on? And it seems no matter what's going on, when a student athlete comes into the AT center, I actually had one yesterday where he was like, oh, it's been hurting for about a year. Okay, this happened to be a sophomore, so he very well could have told us last year or whatnot. And there's different reasons. Maybe they thought it was fine. Maybe, I don't know. There's so many different reasons why they may not disclose initially. But trying to figure out if this is a brand new injury or something that's sustained over a duration of time. We want to make sure we're using discretion. Where is this injury at? A lot of times if we have a hip or a groin injury, maybe females are more comfortable going to me and the males are more comfortable going to one of the male athletic trainers, or vice versa. Okay, we want to make sure we're putting our patients at ease and their comfort level is being taken into consideration. So if I have a volleyball athlete who is wearing spandex and, one of our other male sports teams are in the athletic training center, maybe she feels uncomfortable. Okay, let's take her, in a different room and hopefully put her at ease because she feels like maybe she's on display. So those are things that we're talking about with discretion. Religious considerations, not everybody is open and forthcoming. Sometimes they'll tell you after the fact. Make sure if we have to drape or use discretion that we are doing so. And then informed consent. So we're at the community college level. Almost, not everybody, but almost everybody is 18. Those that are not 18, we send them home with a document for either their parent or guardian to sign a written consent statement saying that the MJC sports medicine program has the ability to look and treat my son or daughter. Okay. Verbal, we always get verbal consent. Usually when the student athlete comes into the athletic training center, they know that we're the athletic trainers and they're trying to get treatment or evaluation, but still, I don't know every single person. So, hi, I'm Jamie. I'm one of the athletic trainers. Is it okay if I, look at you, if I take a look at your injured elbow? Okay. And then emergency medical care. So if you guys have already taken Health Ed 101 or taken a CPR first aid class, you'll have heard or learned about the Good Samaritan Law. Those that have not, the Good Samaritan Law is that you are working and treating that particular patient or person out of the goodness of your heart within your scope of practice, and you're not expecting anything in return. So say you're at a steakhouse and the universal sign for choking is this, okay? And somebody's choking, you want to make sure that you're getting consent. Hey, I've been trained in the Heimlich. Is it okay if I help you? Either they're going to say yes or they're going to say no. If they say yes, then you move forward. If they say no, you're not allowed to touch them. Doesn't matter what their reason is. Normally, I've knock on wood, I haven't had that happen, but if somebody were to say no, I would still stay there. I would call 911 because it's better to have 911 en route and then turn them away when you actually get that obstruction out of their airway. Or if that obstruction doesn't get out of the airway, then they're going to go unconscious. Once they're unconscious, consent is implied, meaning any person of sound mind would want you to help them to the best of your ability. Okay. When you're talking about somebody who's under 18, if there's a parent around, you would ask the parent for consent. If not, I would still ask the person and then go from there. History. So remember when I was talking about hops or soap? This kind of falls in either the subjective or the history, where we're finding out what the mechanism of injury is, what type of history of that body part, if they have any type of underlying pathology. So now's the time to ask if and when you see scars, ask what those scars are from. Is it from scraping your knee, riding your bike, or did they have surgery? And communication skills. Try and avoid yes or no answers. You want to ask open-ended questions. That way you're getting as much detail as possible. That, and then if it is an emergency scenario, the student, athlete, or patient might just give you those yes or no answers, and you want to get as much information as possible. The past medical history includes exams where hopefully they're disclosing their previous health conditions, any injuries, predisposing factors. Are they on any type of medications? Do they have any allergies? How many concussions have they had? Are they, do they have any underlying conditions? Some people will disclose that they're on birth control. Others will disclose that they have depression or anxiety, things like that. It is good. I know we're at the community college level and we don't fall into the NC2A guidelines, but it's good to have that understanding. So I would recommend, and this is at the end of the slideshow, but on box 1.3, it has the different medical evaluations where they're talking about immunizations and records. There are, with NC2A, there are different banned substances where people, usually the athletic trainers, will end up drug testing for steroids or for different things. And if you are at an NC2A institution, you have to make sure you know that stuff and you're advising your patients or your student athletes properly. Okay, with previous history, have they ever been injured on that side? What about the other side? What other injuries, if any, are still going on? There's times where I have an athlete with a shoulder injury, but they also have a low back injury. Are those co-related? Because we're talking about that kinetic chain. Are there any other possible sources of weakness from a previous injury? And there's been a handful of times where I'm evaluating somebody and they're like, oh, I was in a car accident 2 weeks ago. Okay, is that residual from the car accident or is that something new? So these are things that you're kind of like a detective and trying to figure that out. General medical health issues. What is their current health status? Do they have comorbidities that are present? Do they have diabetes? Do they have a blood clotting disorder? Things like this. We as athletic trainers do not order lab work or blood work or anything like that, but if they've recently had something, that's something worth looking into, and because that can affect management or the healing process. Another thing that I talk with our student athletes about is if they happen to be smoking or vaping or using tobacco or smoking marijuana or eating gummies, because those are all different things that can slow the healing process. And sometimes they'll disclose to me, sometimes they won't. Realistically, we end up finding out, not that we're trying to, but we're trying to treat our patients holistically. So the whole patient. And sometimes, it's recreational. Sometimes it's a habit. And that's something that we'll delve into deeper when we go into our psychosocial thing, where we do try and get them help that they need. What type of medications are they on? Do they have any type of interactions? Is this a new medication? Or have they recently stopped a medication, cold turkey? Because that definitely does have an effect on what's going on with them. Again, I just briefly touched on smoking, but it can decrease exercise tolerance, the lung capacity. I know at MJC we've got a respiratory therapy bachelor's degree, and in our cadaver lab they've got great resources where you can look at different types of lungs and what smoking and vaping does to the lungs. So that's something, if you are in anatomy right now, or if you're going to be taking anatomy, that's something to look forward to. With smoking, it does have an increased risk for cardiovascular disease and can delay fracture and wound healing. So those are some things that we do talk about. Now getting into history of what's going on. What was the mechanism of injury? Did they, step off a curb wrong and roll their ankle? Is this repetition that maybe they're wearing old shoes and they don't have the best arch support? So what's going on there? Is it a macro trauma or a micro trauma? Meaning macro is something pretty big or significant, stepping in a hole, rolling your ankle, getting elbowed in the face. Or is it micro trauma where maybe it's just a whole bunch of repetitive overuse micro traumas? Do they have any relevant sounds or sensations for that mechanism of injury? Oh, I heard a pop, or it felt like I got shot in the calf. I don't know why, but every single person who has had their Achilles rupture has always said it feels like they got shot in the calf. And then after the fact, hey, have you ever been shot? No, but that's just what I thought it would feel like. So those are things to kind of take into consideration. The onset or duration of symptoms, we went over this at length in Knies 106. Is it acute or chronic? Is it acute where, bam, it happens right then and there, or is it over a period of time? And then what type of pain is it? There's so many description words for pain. Think of some right now. I know, awkward pause, right? Hopefully you're thinking of different things. Is it sharp, burning, achy, throbby, numbness, tingling, dull? Does it keep you up at night? Where is it at? Does it radiate anywhere? Is it better in the morning and then alleviates throughout the day? There's so many different things. What makes it worse and what makes it better? Oh, well, my low back hurts when I'm sitting in a chair or standing, but when I'm laying down, whether it's prone or supine, it alleviates. Okay, those are all things that we're looking into. And then what other type of symptoms do they have? What have they done currently? Have they iced it? Have they taken any, ibuprofen, things like that? Do they have any other disability or limitations? And when I'm talking about that, does it, like when we're talking about their shoulder, does their range of motion, a lot of times they want to stop right there. Well, with their good arm, they should be able to go all the way up. So we want to make sure we find out what those limitations are. And then goals. Stereotypically in our setting, our goals are to get our student athletes back to 100% and back to participating in their sport, able to do their ADLs, activities of daily living. So when we are doing our physical exam, we want to rule out differential diagnoses where we're looking at multiple things that could be going on, and then we're ideally identifying what the issue is. And then we always need to use our standard precautions against bloodborne pathogens. And now, I know this book is a little bit older, but now I would also include COVID, okay? COVID pathogens. So with bloodborne pathogens, just a little refresher, make sure we're wearing our gloves. But now when we're also talking about COVID, not only gloves when we're touching any type of bodily fluid, but wearing our mask and or if we have glasses or a face shield. I don't know if you guys have been to the hospitals recently, but they do have all their PPE, not pre-participation exam. Now we're talking about personal protective equipment. Inspection. So how are they walking in to the athletic training center? How are they walking off the field towards you? What's their gait? What's their posture? Are they, do they have their arms splinted against their body and their head turned towards them? Then I'm thinking either shoulder or clavicle injury. Okay, so what posture do they have? Are they guarding? Have they splinted a body part towards them, as they're posturing or as they're walking towards you? These are all things that before we even get to talk to our patient, we're inspecting as we're walking up to the injury on the sideline or on the court or on the field. Okay, physical exam, we're observing things bilateral. Is there a subtle or a gross deformity? Or how bad is the swelling? Even if you don't have a tape measure where you're measuring the girth of the body parts, can you visually see and inspect and see that there's swelling? Is it bursitis, where it's inflammation of the bursa sac, where it looks like a water balloon? How is the skin? Do they have any infection signs? Is it red? Is it warm to touch? Things like that. And then now we're with the inspection, now we can go into more of our functional assessment. Are they able to perform functional movement? And then what limitations do they have? That way we can note and minimize those. Now with palpation, there's two different strategies you can use. One's not better than the other. It's going to be based on personal preference, and maybe it may switch based on the situation. Okay, stereotypically, I like to rule out bones or any type of bony involvement, meaning that, you know, I'm sure that there's not a fracture or a dislocation, and then I'll go into the ligaments and soft tissues. Whereas I do also like to palpate the structures away from where it hurts and then towards where it hurts. So ideally, we're asking somebody point with one finger where it hurts, and it never fails. They usually do this. Okay. Ideally, they're going to, you know, point to one spot and not just like the whole thing. So when they do that, that's fine. But now we're palpating and we'll ask A or B, A or B, you know, which one hurts worse. That way we can start identifying the musculature or soft tissues that are going on with that. Where are they point tender? Are there any point tenderness areas, or when we're comparing bilateral, so say I'm palpating the shoulders, is the injured shoulder warmer to touch than the uninjured shoulder? That means there's active swelling going on. Is there a change in tissue density? Is there a knot in the muscles there? Are there any type of crepitus? So right now with crepitus, I would like you to, you know, use your pointer and thumb, put it on your patella tendon, and then flex and extend your knee. Okay. A lot of times you might feel crepitus or that kind of crunching sensation. So that's what we're talking about with crepitus. When we're doing functional assessment, we want to compare bilateral, the good and the bad. And we're comparing ROM, range of motion. Okay, little refresher. So we have active, passive, and resistive range of motion. Active is when the patient is doing it themselves. Passive would be me as the clinician putting their shoulder through flexion without them moving it. And then resistive is where I am palpating or putting pressure on the anterior aspect while they go through the full shoulder flexion. So that resistive range of motion can also be used as the manual muscle testing. And then we're getting into joint play and stress testing, which will go further into detail once we get to each individual body part. So active range of motion, they are doing it themselves. And we're going to always start with that unless it's contraindicated, meaning that there's an obvious deformity or dislocation. I'm not going to necessarily have them move something when, you know, visually, upon visual inspection, we can see that there is definitely an injury there. What is the ease of movement? Were they able to get the full range of motion, or were they compensated? So when I'm talking about shoulder, you know, are they using other muscles to get it all the way up there? Now with manual muscle testing or resistive range of motion, we want to apply pressure, but not so much pressure that it limits their ability to go through the full range of motion. We will stabilize the limb, whether it's, you know, arms or leg, proximally, so closer towards the torso, and apply resistance distally, and then you can grade accordingly. And that's one of the things we will go over when we get to our face-to-face meetings. Passive range of motion, we as the clinicians are doing it. We try not to put overpressure to figure out what the end feel is. And if passive range of motion is better than active range of motion, we're thinking that there's some type of tissue lesion or muscular weakness. Whereas if they are equal, then we think that there's some type of joint tightness or a capsular adhesion. For the joint stability tests, we're looking to see what the mobility is, okay? Are they hypermobile or hypomobile? Hyper, remember, is increase or more laxity than normal. Hypo meaning low or below, means less mobility. Okay, what type of laxity is there? Is there a give or a lot of movement in that joint? And stress testing, these are first, second, and third, or firm, soft, and empty end feels. You guys are more than welcome to go ahead and read that box, but it's giving you, similar to when we've talked about sprains and strains for first, second, third being the most severe, first being least severe. So an empty infeel is where it's completely open. Like if I'm doing a special test, it opens up. Like there's no ligament there or no tendon there. So that usually would indicate a third degree. There are different types of arthrokinematic motions. okay, the way that the bones play on each other. There's rolling, spinning, and gliding. Rolling, think of like rolling a baseball or a bowling ball down. Spinning would be like a top where you're spinning, where it rotates usually either clockwise or counterclockwise. And gliding would be when it is kind of rolling and articulating on one or the other. Okay? We want to make sure that a patient is relaxed, and sometimes that's difficult to get, right? So they're seeing you, they're in pain, and we tell them to relax. That doesn't put their mind more at ease. So if it's a lower body injury that I'm trying to do a special test, a lot of times I will have them grab their arm or their fingers together and pull apart. That way it gives them something to do and focus on, and usually the lower body will start, loosening up. Now, if it's upper body, you can have them, press down like they're pressing a gas pedal and just try and alter their focus in that manner, but it's usually easier if we're looking at the lower extremity. Special tests. We're getting into the special tests, and those are going to be for each of the different body parts. Okay, down at the bottom, look and see how it's reported as a positive would be a plus symbol, or a negative would be a negative symbol. So when we're looking at these special tests are going to be unique to each structure. So the shoulder is going to have different special test names than the ankle or the knee. So when we get into each of those, and that's a lot of what this course is looking at the different special tests of each of the individual body parts. Now, I've always said we're going to do a neurological screen, and we will do upper and lower quarter screenings where we're talking about the myotomes, myo meaning muscle, so how it moves, different things. Dermatomes, derm meaning skin, so the skin sensation, is it sharp, can they feel which finger you're touching without them visually looking at it, or reflexes, okay? So sensation would be dermatomes, motor function is myotomes, and tendon reflexes. There's only, I want to say 2 in the lower body, which is the patellar tendon and the Achilles tendon, and there's 3 in the upper body, which would be the tricep tendon, the brachioradialis, and the ulnaris. Okay, we will get into each of those because what muscles articulate with that particular nerve are going to have diminished sensation and movement. Okay, dermatomes, area of the skin. We're comparing bilateral, so, does this feel the same? And I would go through the whole entire thing. Again, the upper quarter screen and lower quarter screen is something that we're going to learn later on in the semester when we are face-to-face. When we are doing these, we have the patient with their eyes closed and or head turned away. That way, like when we're asking, what finger am I touching? We don't want them to visually see and tell us because they visually inspected it. We want to get the actual sensation. Okay. And then also with this sensation of dermatomes, light touch compared to sharp or dull. So I don't always have one of those tools out on the sidelines with me. Usually you can use your fingers for kind of light touch, and I usually have a pen in my hair, and you can use either the ball point of the pen or the cap of the pen and see if that feels or has a different sensation than the other one. Now motor testing, and that's the muscle, and there are different acronyms that we will go into. This is just kind of reviewing and getting us into this course. But with the neurological screening, if they have diminished movement on a particular side, or if one muscle is weak, then we're thinking that that peripheral nerve has some type of impingement or deficiency. So we will look into that. Now, if both muscles are weak, bilateral, then we think that the nerve root has some type of pushing or impingement on it. Reflexes, I told you guys, there's only a handful of them, and it takes practice, and every time we end up having this lab, I have to re-practice it all over again. More so the upper extremity than the lower extremity. Lower extremity is fairly routine. Upper extremity, it's because like when you're using the reflex hammer, you're not just hitting it on the tendon sometimes. Sometimes you have your thumb on, you can't see, on the actual tendon and you're hitting the nail bed of your thumb. So, and it's different for every body and every body part. So that's something that when you're doing those deep tendon reflexes that you want to make sure you practice. And these are just the different ways that you grade deep tendon. Usually a 2 is going to be a normal response. 3 or 4 is hyperactive, where it's super sensitive, whereas 1 or 0, it's hypo, meaning less movement or less sensation. And vascular screening. Okay, we've gone through this at length in Kines 106 when we've talked about CSM or PMS. Okay, CSM, circulation, movement, C, circulation, S, sensation, M is movement, or PMS, not premenstrual syndrome, but pulse motor sensation. Okay, and it's going to be different for the upper quarter as it is for the lower quarter. The systemic is going to be the carotid when you're checking a pulse on either side of the carotid. Cap refill, either on the fingers or the toes, where you're pinching and then releasing, and then within 2 seconds it should get back to the normal color. I would encourage you, if you happen to go up to the snow or something anytime soon, also do a cap refill up in the snow, and it's going to be a little bit delayed. It's going to take longer for you to get that sensation or that coloration back. For upper extremity and the pulses, you've got your brachial. And again, remember when we're checking our pulses, we're using our index and our middle finger, not our thumb. Our thumb has its own pulse, and you can misconstrue your own pulse for theirs. So when you're checking the pulse, whether it's the carotid, and that's the systemic, you've got your brachial, which we'll use a lot more on infants, where you're pushing the brachial artery up against the humerus. You've got your radial on the thumb side and ulnar on the pinky side. Now on the lower extremity, you've got the femoral, kind of in the creases of your hips, the posterior tibial, and the dorsal pedal. And again, we'll have pictures of those, and we will be practicing those when we get face to face. And then last but certainly not least, the role of evidence in the examination process. So we want to make sure we're practicing within EBP, evidence-based practice. And with that, normally I would have a whiteboard. I don't have one at home, so I apologize, but think of a Venn diagram with 3 circles around it, where one circle has the clinician's experience, another circle has the patient's morals and values, take into consideration if they have any type of religious or other things. And then the third is best clinical evidence. So hopefully we're still reading and keeping up to date on peer-reviewed journal articles. That way, when new things come out, we're able to give the best healthcare to our patients. So when you have those 3 circles overlapping, and in between that where they're all 3 overlap, that is EBP, evidence-based practice. So we want to make sure we're taking into consideration the patient, the clinician's experience, and the most recent evidence that's out there. Okay, and that's where we're trying to practice within healthcare and also within our examination process. We want to use the best evidence. That way it's efficient. We eliminate time wasted on basically performing unnecessary special tests. Full disclosure, when I was first out of undergrad, I did every single special test for the knee when I'm looking at a knee evaluation, or I did every single special test on whatever body part because I was afraid of missing things. But with that came experience, and when I'm getting a history, now I don't have to do every single one of those special tests. Now I already have, okay, you know what, I think it potentially could be this or this, so I'm going to, perform those. And once I perform those, I might start adding more special tests that I'm taking to it because I don't want to have confirmation bias. So, taking that with a grain of salt. It will make our examination process more accurate and will definitely eliminate false positives. All right, all, that was it for today's lecture. I appreciate you coming, and I will see you shortly.